Hello, today we're going to be talking about the cerebellopontine angle cistern and abnormalities that can occur there. We want to be able to describe the anatomy of the area to understand what can occur there. We want to know the full differential for the cerebellopontine angle mass and understand the imaging features that differentiate between the different types of masses that occur here. So first, the anatomy. We have the pons and the cerebellum, and we have a small area that simulates a mass within the cerebellopontine angle, and that's the flocculus. It's a normal part of the cerebellum. We can see the internal auditory canal, the IAC, which contains several nerves. We can variably see vessels coursing in the area. If we reformat this volumetric image into a plane with respect to the IAC, we can see the normal nerves within the IAC, which can help us in determining where a mass is arising from if there is a mass in this location. The image right is going to be anterior and the image left is posterior. You can see the cerebellum posteriorly to the IAC. Anteriorly and superiorly we have the facial nerve, and you can remember that's anterior and superior because the facial nerve canal runs superior to the cochlea. Anteriorly and inferiorly we have the cochlear nerve because the cochlea is below the facial nerve. Posteriorly we have the superior and inferior divisions of the vestibular nerve. These are some of the differential considerations for a mass occurring within the CP angle cistern. Vestibular schwannomas are going to be the most common, making up 80% of the masses, and we're going to look at exactly how these appear. Meningiomas are second most common, and of course you can have metastatic disease in this area, and should always be a consideration. The third most common mass would be an epidermoid cyst, and we'll talk about the very specific imaging appearance of those. You can get arachnoid cysts as well, and multiple other types of lesions. But again, our main differential and top consideration should be the more common etiologies. And we should consider the other types of entities only when the imaging features are unusual. When you see a mass in the area of the CP angle cistern, we want to think about a couple different questions. What sequence should we review when evaluating a non-enhancing mass? And what characteristics would differentiate a schwannoma from a meningioma? In our first case, we have a large mass located in the left CP angle cistern, which demonstrates homogeneous post-contrast enhancement and exerts mass effect on the pons and on the cerebellum, deviating it to the right and narrowing the right CP angle cistern. The mass involves the left IAC and has a ice cream cone appearance. This would be most consistent with a schwannoma. An important thing to remember is that schwannomas arise from Schwann cells. The cisternal portion of the vestibular nerve does not have Schwann cells, but the canalicular IAC portion of the vestibular nerve does have Schwann cells. So all vestibular nerve schwannomas arise within the IAC and extend outward into the CP angle cistern. Our next case is a right-sided CP angle cistern mass, exerting mass effect on the pons. We have homogeneous post-contrast enhancement and a very small site of extension into the right IAC. There may be an early dural tail here. This mass turned out to be a meningioma. The imaging characteristics that you want to look for is a broad dural attachment, as we have in this case, any sign of a dural tail, enhancement that extends away from the mass and along the dura. You want to look for associated hyperostosis or increased bone formation in the area of the mass. On CT, you'll look for calcifications and again hyperostosis. Next, we have a patient with bilateral CP angle cistern masses and involvement of the IACs. On the left, we see there's been a prior resection with recurrent enhancement. And on the right, we see a classic ice cream cone configuration of a schwannoma. When you have bilateral schwannomas, this is diagnostic of the autosomal dominant phakomatosis, neurofibromatosis type 2. Remember to look for meningiomas and spinal ependymomas in these patients. Now, bilateral schwannomas are diagnostic of NF2, but bilateral enhancing masses in the IAC could be something else like metastatic disease. Here we have another case of a left cepiangle cistern mass with homogeneous post-contrast enhancement. We see a cleft of CSF between the mass and the pons in the cerebellum. This mass does not extend into the IAC, but also does not have a broad area of attachment with the dura. In fact, it has a narrow area of attachment with the dura. This turns out to be a hemangiopericytoma. These can have a very similar appearance to meningiomas, and it's difficult to tell them apart, particularly because meningiomas are so much more common and can have a variable appearance. Things to know about hemangiopericytomas to differentiate them from meningiomas include lack of calcification. They tend to erode bone rather than cause hyperostosis, and they tend to have a narrow base of attachment to the dura rather than a broad base of attachment. Our next case, we have a CSF signal intensity mass within the right cepiangle cistern. This is bright on a T2 weighted sequence, CSF signal on a T1 weighted sequence, and suppresses with fluid attenuated inversion recovery, FLAIR, and does not demonstrate restricted diffusion. This is a small cepiangle cistern arachnoid cyst. Again, arachnoid cysts should follow CSF signal intensity on all sequences. On the top left, we have a T2 weighted sequence. On the right, a post-contrast T1 sequence. Bottom left is a FLAIR sequence. Bottom right is our diffusion sequence. Top left, we see T2 signal hyperintensity close to that of CSF. The mass does not enhance. The mass insinuates itself into portions of the pons and cerebellum, almost like it has tentacles. And the mass does not demonstrate complete CSF signal suppression on the FLAIR sequence. There are dark areas that do suppress on FLAIR, but plenty of areas of intermediate signal and elevated signal that do not suppress. This mass also demonstrates restricted diffusion and is characteristic of an epidermoid. Here we have a small mass. This is a post-contrast T1 weighted sequence. We see it's post-contrast because there's enhancement of the nasal mucosa, but whenever you see something that's bright on the post-contrast sequence, make sure that it wasn't bright before we gave contrast. And so this turns out to be a small lipoma that suppresses with fat suppression. Here's a patient with bilateral nodular enhancement within the IACs, extending to the cepiangle cistern, and also abnormal enhancement within the fourth ventricle. This turns out to be leptomeningeal spread of a choroid plexus papilloma. Remember to keep leptomeningeal spread of disease and other metastatic disease on the differential for cepiangle cistern lesions. Here's another case of metastatic disease. We can tell because there's two enhancing lesions within the right cerebellum. This should not be mistaken for an extraaxial lesion. This is actually intraaxial. You can see a great deal of surrounding vasogenic edema. And these are two ring-enhancing metastatic sites. To review, our main differential for cepiangle cistern mass is going to be schwannoma, meningioma, and epidermoid. Epidermoids insinuate themselves along the brain, they don't enhance, and they restrict diffusion. Schwannomas start within the IAC and have an ice cream cone appearance. Meningiomas will have a dural tail with a broad attachment with the dura and can cause hyperostosis. We want to think about the most common entities and put them at the top of our differential, but also keep in the back of our mind other things that can occur in these regions. Thank you very much for your time.